So welcome everybody. It is really lovely to see so many people from diverse organisations, peer researchers, colleagues in academia, clinicians, students, third sector. It's great. So yeah, because we all work together to try and achieve the same aim. And it's almost as though we planned it, but this morning some of you will have seen in The Guardian on the front page that there's a commentary about children and young people trying to access CAMH-Crisis services. And in the article, which was a press release from the Royal College of Psychiatrists, they're saying that in 2022-23, 32,000 referrals were made to CAMH-Crisis services. And that is a 50% increase on 2019 and 2020. So we all know this, don't we? We all know that there's a problem. Anyway, so our project, decided not to move on. Our project was an evidence synthesis. CAMH-Crisis, or CAMH-Crisis 1, was an evidence synthesis where we looked at all the international literature that we could find and some of the UK-based policy documents and grey literature, looking at the different models of providing crisis care. And we're not interested in only CAMHS and NHS provision. We're interested in anything provided by local authorities, schools, third sector, online. So we were doing a great scope looking at that. And the objectives of our evidence synthesis were to have a look at what exactly are the goals of any service provision, or crisis service provision. Well, how are they organised? So what are the different models? Which ones of them are effective? And what do people working in them and using them think? And we thought long and hard about the age range of such services and who we should include and exclude. And I suppose we're super mindful of what happens after 18. So 18 to 25, there are transition issues. We know that internationally services are moving more towards youth or including youth as maybe even a separate group of services. So we decided to include the age range 5 to 25. I'm sure people have got comments about the under fives. We kind of thought problems, crises under fives were probably parents struggling really with parenting. And what we found? Well, what we found was that the goals of most crisis services, number one, keep the child or the young person at home wherever possible and where it's safe to do so. Number two, to try and stabilise the situation. So whatever the mental health crisis is, to just kind of take the edge off it, calm it, contain it. We had 7 goals actually, but the third important one I thought was to think about was crisis services offer a great help to other organisations in terms of consultation and training. So specific crisis services might help other departments like emergency departments or schools or a local authority in learning how to manage crisis situations. We did find 3 key groups of how services were organised. There was the first group, which we call triage or assessment only services, and they were found in all sorts of organisations, so schools, hospitals, online, phone, that kind of organisation. We also grouped another whole section of services together that we've called digitally mediated. These are your chat rooms online, your phone calls, or your texts. And again, they can be offered by various organisations. And then the third group of crisis services or models were those that offered not only an assessment, but an intervention. And sometimes the intervention lasted a few hours, and sometimes it offered a follow-up. There was evidence that some models and some services are effective. The school models, there was only a few studies about school models, and the way that they measured whether they were effective is that there were no suicide attempts after people had contacted the crisis services. So that was their metric. We also found that lots and lots of literature saying that emergency departments in hospital do offer an effective intervention at managing mental health crises. And I'll say a little bit more about that later on. And community services were really good at both containing the crisis, but also helping to link the child or young person up with a community follow-up service to avoid any ongoing hospitalisation. But I think some of the most important information that we found from the evidence review was hearing about what families and children and young people thought of services, and two great big issues. The first one is families, children, young people, and practitioners actually don't know where to go to access crisis services. So even though we think we're doing a reasonable job of signposting and advertising, that's still getting lost. And people are also saying that, or there was evidence that even when they knew where to go, they may not meet the criteria for access. So we know that's sometimes about age. We know it's sometimes about where someone lives in relation to where the service is. And sometimes it's about they just haven't got the money or the facility to cross town to get it. And finally, what children, young people and families really wanted was something before the crisis emerged. So if they could get more help before. Oops. Okay, so what?
You've got 1 minute left, Nick.
Okay, so what's the key learning from our studies is that children and young people don't know where to get services, that all sorts of digitally mediated services are very welcome. Children and young people would really like to talk to other children and young people if possible. And although emergency department attendance is stressful, it works. And this we know is not the UK policy. But what we did find from all of that evidence, only 3 studies came from the UK. And we know in the UK there are lots of services that offer crisis, but these have not been researched to date. So we developed and got funded for CAMH-Crisis 2, which is a study that's ongoing. We're generating data now. We've done the 3 work packages. The first is looking at the services across England and Wales, what models they are. Work package 2 we're in the middle of, which is investigating 8 case studies and seeing how they work, and then we're bringing them together. And this is just a sneak view of work in progress about what the models are that we think operate in England and Wales offering crisis services. Please don't share this last slide. Thank you.
Let's move straight on to our second speaker. That's Georgia Naughton. Georgia is a peer researcher at the fabulous McPin Foundation and was also involved in the Blueprint project. And we're going to hear now from Georgia about how young people were involved in that work. Over to you, Georgia.
Thank you. So the aim of the Blueprint project was to develop a model of effective service design for children and young people experiencing common mental health problems. One of the main aspirations of this research was to move beyond the PPI advisory role and have lived experience roles further embedded in a more collaborative capacity. So data generation was rooted in lived experience. The Blueprint project did this by working with young people co-researchers as active members of the research team, which then led us to creating some guidelines to this involvement. So PPI is widely acknowledged as an essential component of research, as we all know. However, we found that there seems to be a lack of practical guidance on how to involve young people. The current guidance seems to focus more on why rather than how, and is more theoretical and aspirational. So this means there's a lack of guidance in relation to involving young people as active members of the research team. We also came to realise quite early on in the project there are a few challenges in relation to employment, status and governance when trying to involve young people as members of the research team. To overcome these challenges, the project collaborated with a third sector partner, the McPin Foundation, which is a mental health research charity which prioritises lived experience in its research. So the co-researchers were recruited, trained and employed, and there were 6 of us, aged 18 to 25, who had lived experience of common mental health problems. And the co-researchers worked in partnership with the academic researchers on the project, based at the universities of Manchester and Cardiff. And we received ongoing training and supervision from the University of Manchester and mentoring and support from the McPin Foundation. So at the beginning of our role, we received research methods training, which covered things like ethics, research ethics, qualitative research methods, interviewing skills, just everything we needed for the role. We then went on to co-interview children and young people service users, parents and carers, mental health service providers, via video call alongside the lead researcher. We also assisted with data analysis, so we're involved in the coding and the theme formation. And throughout our involvement, we're able to use our lived experience, which enabled us to empathise and interpret the interview data in a way that someone without this lived experience may not be able to. Some of the other things we did was co-design and record a video version of the participation information sheet to increase accessibility and support study recruitment. We attended advisory group meetings, research team meetings, and one of the larger things we did in our involvement was write reflective summaries about our co-researcher journey, which was later used for our involvement paper, which we were all co-authors on. And I'll talk more about that in a bit. And some of us were also involved in dissemination activities, including presenting a poster at Children and Young People's Mental Health Conference in Copenhagen in 2022, and helping to create the animation video that you all saw earlier, which showed the research findings of the project. So some of the reflections we had on the co-researcher role, the main one was that we value and lived experience. This was valued throughout and so it was central to the project. We all found that this was a really rare opportunity to get first-hand research experience. A lot of places out there needed experience, but it was hard to get that experience in the first place. So this was, a really rare opportunity. It was a flexible and manageable project workload. A lot of us had other commitments, university, other jobs, so we were able to work this around those quite easily. They used an individual and tailored approach to co-interviewing, so we can ask as many or little questions as we felt comfortable, which really helped us build our confidence around interviewing. It also led to great personal and professional benefits, lots of new skills, research knowledge, which then led to new roles in full-time research roles like myself and a couple of other people, and also led to further study in research and healthcare for some of us as well. We did find that there were some challenges working as a co-researcher, such as restricted hours to do with how much money was available for us, remote working at the time could be quite isolating at times. We never actually saw each other in person at the beginning. There was also delays due to COVID, which obviously couldn't be helped. So from these reflections, we decided to develop the guidelines for our involvement, which were called a blueprint for involvement, which we're all co-authors on. So we all wrote our reflexive pieces and then we analysed using thematic analysis and wrote this up into a paper. So we hope this paper, based on our shared learning, that will inspire more research teams to incorporate active co-researchers into their projects. And we also just wanted to point out that we won an outstanding contribution to PPIE Awards in 2023 because of this work that we did. And if you want to read more about it, this is the co-researcher reflection paper, the qualitative outcome paper, and we've also got the main paper that's been published since these slides were made as well. That's everything from me. Thank you.
So our final speaker is Professor Pryjmachuk from the University of Manchester. Stephen is mental health nursing professor there, and he's going to carry on from what Georgia was saying there and tell us more about this Blueprint project and the findings. Thank you, Stephen.
This is the same project as the project that Georgia has just talked about, which is colloquially known as the Blueprint Project. It was termed Blueprint by our advisory young people on the advisory group, termed it Blueprint, but for some reason the NHR didn't like it and they won't let us use it in the final report, but we still call it Blueprint. Everybody who's involved in it still knows it as Blueprint. Anyway, what did we do? So, 43-month project, 43 months, discussed in 5 minutes. I'll do my best to get as much as I can in 5 minutes. Started in October 2018 and went through to April 2022. And it was extended, of course, as most research projects were during that period because of COVID. Four work streams in the project. The first work stream was doing some literature reviews. One, we did use the same literature, but we had a scoping review and something called an integrative review, which is more about the evidence. Scoping is about what's going on. The integrative review is about the evidence. Then we did a service map across England and Wales. Then we did some case studies of services across England and Wales drawn from the service map. And if you can see some parallels between what we did and what's going on in CAMH-Crisis 2 and CAMH-Crisis, that's no surprise really, because Nick and I have worked together, so we're both on the same team. And the final work stream was to do something with all of this information that we'd got, to develop a model, or as we put in the original proposal, we might end up with models of high quality service design for children and young people with common mental health problems. So the scoping review really, we found 342 service descriptions in the international literature in 296 documents. And then we tried to sort of categorise them. And we came up with 6 broad groups, as you can see on the slide here, and then another group that we called service transformation frameworks that cut across these groups. But I'm not going to dwell on this too much because, as you'll see shortly, our conclusions actually don't really take into account these different model types. From the integrative review, which ran parallel to the scoping review, we didn't actually find a great deal of evidence, and the strongest evidence we did find was for a model called collaborative care. We also found a little bit of evidence for brief intervention approaches, which seems to be particularly good at managing waiting lists. In terms of acceptability, and what I mean by acceptability is what children, young people, families, and those delivering services thought about the different models. There wasn't really any model that had superiority over the other models. But what we did find is that effective and acceptable services seem to be underpinned by some common themes. I doubt any of these will be a surprise to people working in children and young people's mental health. Few barriers to access, some degree of interagency working, the use of consultation liaison approaches, and a consideration of the wider service culture. So in terms of the service map, this is England and Wales only, the literature review was international. We found 154 services provided by 123 unique service providers. The majority, of course, operated in in England. There were a few that were actually pan-UK services. Most were urban and metro services. Equally run by the statutory and third sectors. We actually had some private sector provision as well. Self-referral routes, far more common in the third sector than the NHS, though surprisingly for us, we found that more than half of NHS services that were in the map offered self-referral. Community outreach models, which was one of our big groups, Group D, which included schools outreach, outreach to home, community outreach, and liaison services, was the most common approach in England and Wales. And really, the map was, one of the primary purposes of the map was to give us a sampling frame for work stream 3, which was sampling, which was the case study work stream. So then we went to 9 sites, 4 in England, 3 in Wales, 2 across England, and working across England and Wales. And these sites reflected all of the models that we got in that typology that was presented earlier. We had a mix of providers as well, 4 NHS, 3 third sector, 1 private and 1 joint third sector. We had to collect data, all of it had to be collected remotely, because just as we were about to go into data collection, COVID hit. We did 108, we had 108 participants, 96 semi-structured interviews, and as Georgia mentioned, we had 6 paid young co-researchers who assisted with the data collection. So the case study research is actually summarised in a paper. There's a reference at the end for this paper. It's an open access paper, so anybody can access it. And the case study research really led to four themes about effectiveness and acceptability: open access, therapeutic relationships, personalisation, development of self-care skills. We then sort of took the data from the integrative literature review and the case study, and then we had some teamwork to synthesize them all together in a model. Technically, it's a meta model, but it just gets complicated if you start throwing in additional terms. So we're just calling it a model. And the blue and green diagram there is our model. If you look at those, I mean, and the slides will be available, and if you link to our website as well, this diagram's there. Most of those model components are consistent with what's been in the literature for years. But our model also stresses a few additional things, such as aftercare. And we prefer the term "what happens next," because it isn't just about transitions from children's services to adult services. It's about everybody who comes into the service and then comes out. A learning culture, also about balancing confidentiality and safeguarding. So practically, what does it all mean? Well, our big observation is we looked at 300 international documents. We had an in-depth set of primary research involving more than 100 stakeholder interviews. And we actually found that a lot of what we found has been consistent in the literature for 15 years, but it's had very little impact on service provision. We actually would argue that the generic building blocks, such as those things in our model, are more useful than some, often imposed specific models. As I mentioned before, aftercare arrangements are important. Learning culture is important, but it's more than staff training and development. Stakeholders want much more information about services. Personalisation is important, and that means choices should be available. And my final point really is that statutory services might want to explore why the private and third sectors seem to be far more agile in terms of offering choice, personalisation and flexibility. We probably know all of the reasons behind it, but that was a key finding that came from our project. Final slide, we've got 2 academic papers published, which are the first 2. They're both open access. Study website's got some more information, including links to the animation that you saw earlier on. And if anybody wants to read it, there's a 50,000-word report currently being prepared. That will be on the NHIR website shortly. Thank you very much.